I'm Dr. Allan Perel, and this is Conversations in Medicine. This program brings cutting-edge medical topics to the Staten Island, New York City, and tri-state area. Today's program will focus on pulmonary medicine, or lung disease or lung medicine. There are many lung disorders, and on Staten Island and in New York City, but Staten Island particularly, there's a very high incidence of lung disease, particularly asthma, chronic obstructive pulmonary disease, or we've heard of COPD, and lung cancer. We will discuss these issues at great length today. Lung cancer is the third most common cause of cancer. It's the #1 killer. Smoking, pollution are all contributing factors to lung disease and cancer. On Staten Island, every year for the last few years, 350 new people were diagnosed with lung cancer. My esteemed expert guests are Dr. Keith Diaz, who is an intensivist at Richmond University Medical Center and the director of the lung cancer screening program at Rumsey. Welcome.
Thank you.
And Dr. Jay Fenoyam, who is the vice chair of the Department of Medicine at Richmond University Medical Center and the chief of their critical care units. Again, thank you and welcome. So tell us a little bit about risk factors for lung disease, and especially on Staten Island and the New York City area, Keith.
In general, the risk factors for lung disease is definitely some hereditary or genetics that may put the person at some predisposition. But the majority of illnesses are caused by exposure or inhalation of certain particles, noxious odors, smoke, pollutants, and that reacts in some way with that person and their genetic predisposition. In Staten Island, we've come a long way, but about 15 years ago or so, we had a very high incidence of smoking on Staten Island. It was about close to 30%, which was much higher than a national average. In recent years, we've definitely improved on that, majority of that being with the help of Mayor Bloomberg actually putting into process the banning on smoking in public places. But I think that high incidence of smoking, we're now seeing a lot of the repercussions or disease entities now in combination with all the environmental factors that we have.
So we're hopeful that over the next few years, because smoking is less, hopefully some of these lung diseases might be less. So we see it's a shocking number that 3 out of 10 people smoked on Staten Island about 10 or 15 years ago when that data came out. And that's really staggering. So tell us a little bit about the risk assessment for someone to see if they have lung cancer and what tests could they have. So say someone smoked up until 5 or 10 years ago and they're concerned. I mean, they've got a family, they've smoked a lot of years, they smoked a lot of what we call pack years, and they come to you as a pulmonologist or the regular internist and say, I'm really concerned. Or if you just happen to be their doctor, the regular primary care physician, you see someone who might be at increased risk because of their smoking or because there's a family history. What kind of things could you do to screen these people to find the cancer early? And we'll talk about what that means.
Until recently, there wasn't any screening in process, and we know we have a lot of different types of screening for other types of cancers. But fairly recently, there was a large study that looked at people who were considered to be at high risk for developing lung cancer. So those patients were between the ages of 55 and 75. They were what we consider heavy smokers, so they would have had to have smoked 30 pack years or more. And a pack year essentially means that if you smoke 1 pack of cigarettes for 1 year, that's a pack year. If you smoke 2 packs of cigarettes for 1 year, then that would be considered 2 pack years. So there is definitely what we think is called a dose response, meaning the more you smoke, the higher your chances are. And if these people fit the criteria where if they smoked more than 30 pack years, they were within that age group, they were screened either with a low-dose CAT scan of the chest versus a chest x-ray. And what they found is that they could find cancer at a much earlier period. So we know that when we diagnose cancer in an earlier stage, there are much better treatment options, and the outcome is usually better.
And it's always better to diagnose things earlier and when things are smaller. So tell me a little bit, tell everybody, what's a CAT scan? So what's a people are concerned about X-ray exposure causing cancer. Chest X-rays, a CAT scan is a kind of an X-ray or radiograph or kind of procedure. Tell us a little bit about it. And when you say low dose, should people not be concerned that they're going to develop some illness because of the radiation?
We have gotten better at the technology, so a traditional CAT scan is essentially a bunch of X-rays where it can give you a three-dimensional picture of inside the body, as opposed to a two-dimensional picture of an X-ray. So that it is a series of X-rays. A traditional CAT scan was a very high significant, or is a more significant dose of radiation. And they measure the radiation dose in something called millisieverts. So that a traditional CAT scan is about 7 or 8 millisieverts. A regular chest X-ray is about 0.2 millisieverts. So there's quite a big disparity there. The low-dose CAT scan is about 1.4 millisieverts, so it's much less than a traditional CAT scan. And in general, we can still get excellent information from the test, and we can see these cancers at a much earlier time by giving a very low-dose scan. It's a very quick, painless test. It takes approximately less than a minute really to actually do the test itself. Many people are somewhat concerned if they have claustrophobia, are they going to be able to perform this kind of test? And really it's an open, almost looks like a donut, so your body is going through it, not necessarily enclosed in it.
So it's not an MRI?
No.
Everyone's always
exactly.
concerned about an MRI being in a coffin-like tunnel. Here it's really much more open, like a donut. Say the CAT scan, the low dose, the low radiation CAT scan is normal. Do you do them again? How often do you do it?
For these particular high-risk people that we've identified, we do it, if it's completely normal, we do it annually. Unfortunately, with screening, sometimes we find what we call false positives. So there are some findings sometimes that require further CAT scans that we would do at a shorter time period, 3 months, 6 months, or a year, depending on what that finding might be. But if it's normal, we would do it once a year.
But this is not routine. This is not like a colonoscopy or a mammogram in women to evaluate their breast. This is a test that's in a special group. So it's not everyone who's a certain age or everyone who's a certain sex or everyone who smoked even.
Correct. It's everyone who fits within that age criteria who did have at least an extensive smoking history.
Okay. And what if you find something? What do you do next?
So that really depends on what exactly we do find. As I mentioned, there are a large percent, and when I say large, about 25% will have something there. The majority are what we call nodules. Nodules are essentially a little spot. They could be a small spot versus a large spot, and really size is one of the most important characteristics that we look at to determine if it's going to be something to be concerned about. The majority of them that we do find are, say, less than 6 millimeters. And when they're that small, about 99+% of them are likely to never become anything and are actually quite commonly found about 25% of the time. So those people we still, based on studies that we've seen, they're not likely to develop into cancer. So we would actually continue to watch them every year, once a year. If something is larger, then we might opt to do a shorter term CAT scan, so in maybe 3 months if it's very concerning, versus 6 months. Or we may opt to actually do a biopsy if it's large enough and has certain characteristics. Sometimes we'll also opt for something called a PET scan, which would give us more information looking at the whole body, and also it gives us some likelihood if it is more likely to be a cancer versus not.
If someone is diagnosed with lung cancer, so we've done these screening tests and we see something that looks like a cancer, is that a death sentence for a patient?
Absolutely not. I think the major reason we're doing this screening and the implementation is that we were able to show that we can save lives. And traditionally what we've found is without the screening process, cancers were found in stage, about 70% were found in stage 3 or 4. And those are, much more advanced, the treatment options are much less, and the outcome and mortality are much higher. So that with the implementation of screening, it's actually flip-flop. So now we find 70% in stage 1 or 2. And there's a large potential for cure, actually, in a majority of, people who are in stage 1 or 2.
So caught early, like almost every cancer, this is a very treatable process.
Absolutely.
So Dr. Fenoim, Jay, when we work in the hospital, we see a lot of patients with lung cancer. Tell me, when you deal with a lot with residents, when one of the residents comes to you and says one of our patients has lung cancer and they're concerned about whether they're going to survive or not, how do you encourage them when you see one of those kind of patients?
And usually, the staging is what is most important as far as how well they're going to do, and I let the residents know that in discussing the outcome of that patient, usually with the involvement of the oncologist, I wouldn't do that by myself. We'll get the oncologist involved to have those discussions. But this stage is extremely important and how well they do. Yeah.
And it's interesting because I think teaching young doctors not to think that people who have lung cancer will not survive. And again, if there are patients who do have more advanced disease and sometimes come to the hospital months or years after their diagnosis, sometimes things are much more tragic because of spread. But that's a marvelous program. And do you think that program is being utilized enough?
I wish I could say yes, but I definitely think that we need to continue to encourage physicians, even family members, employees, to really put the word out there, because it is a relatively new idea. People have been doing colonoscopies, mammograms for many years, but this is something that I think still is not as commonly known. And lung cancer is the #1 cancer killer, as you mentioned. So I think that we could be saving more lives.
Okay, so that's important. So if you're concerned with, if you've had a history of smoking or some of the other risk factors in the right age group, you should talk to your primary care physician and really see if you'd be eligible for it. That's why we have a program like this, in order to educate, in order to empower people to know what kind of things are available. Sometimes things aren't always brought up, sometimes things aren't at the forefront, and it's very nice to hear that. So now we're going to change gears a little bit. Let's talk about asthma. I mean, talk about more common lung disorders. What do you do with someone? How do you diagnose asthma? Everybody I know in my daughter's school says they have asthma. It's either too cold and they're wheezing, or they have some allergy and they have seasonal allergies and they have a little bit of a wheeze. Is every wheeze asthma, and how do we diagnose it?
The majority of asthma, and it is a very common disease, probably about 1 in 14, 1 in 13 people are diagnosed with asthma. There are a lot of mimickers of asthma, but essentially most of the time it is a clinical diagnosis, so that someone may have typical signs and symptoms of that disease, and usually they would respond to treatment in a typical manner.
But what is asthma? What does it have to do with what the breathing airways become? Tell us a little bit.
So asthma is, for the most part, a process that's induced by an allergy or a reaction for your immune system to products that are inhaled, whether it be pollen, dust, could be smoke, so that when you inhale these products, the body reacts to them in a way that it sees them as foreign. And this causes inflammation in the airways. The cells within the airways make a lot of excess mucus, which can be very thick and difficult to expectorate. The muscles in the airways actually constrict. So all of this causes a lot of narrowing within the airway, and that makes it very difficult for people to breathe. They often have a lot of excessive coughing, and that causes that typical whistling or wheezing sound that many people explain.
In some cases, and I'll go to Dr. Fenoim, as director of the critical care units, do you see, we've heard of cases, sad to say, of children, young adults, even older patients, a little bit less commonly in older patients, who've wound up in the intensive care unit or even have died of asthma. What happens and what do you do for them?
I mean, asthma, as Dr. Diaz mentioned, with inflammation, it's a reversible condition. But in some patients, some individuals that get the regular treatment, you give the bronchodilators, you give some steroids, and it doesn't improve, and they feel like they're choking. So some of these patients end up in the ICU, and for a lot of those who end up in the ICU, not all, but a good number of those patients might really need ventilatory support.
So they need to be on a respirator.
They could be on a respirator when they come to the ICU, and there are special ways that you need to ventilate these patients. You don't ventilate them like somebody who has pneumonia or any other lung disease. At times you really need to sedate these patients, even to the extent of paralyzing them, because you need to be able to let the ventilator breathe for that patient, and so they don't get to trap a lot of air while you're doing the regular treatment, giving the bronchodilators and steroids at the same time.
So when would you say I have a relative who has asthma or a patient who has asthma? When should they go to the hospital? When do you think, when in the hospital should they wind up in the ICU? How do you know?
Well, there are different severities of asthma. So some people have very significant triggers. What most pulmonologists or lung doctors do, I think they develop individualized treatment plans and make the patient a part of that treatment plan, meaning that we actually have asthma action plans that can be printed on the internet, and we individualize them so that there are kind of 3 different zones, if you will. A green zone, that the person is taking their medication, and or maybe they don't require daily medication, they take something just intermittently. And we often monitor them with something called a peak flow meter. So that's a little handheld device that they blow into, and that's a marker of how narrow their airways are or how significant their asthma might be that day. So that by doing that when they're well, we know what their baseline might be. Then we have maybe a yellow zone where they start to develop increased symptoms, and we can come up with a plan. If we know their triggers, to hopefully avoid those triggers, or we can have medications on hand for them to maybe escalate their therapy somewhat. And if their symptoms are either getting worse or not improving with some measures, we would call that the red zone, and that is when probably somebody should seek medical attention.
Okay. We're going to move on to another lung disease, and that's COPD, chronic obstructive pulmonary or lung disease. I think it was interesting that one of the first authors who wrote a paper about it wanted to call it COLD, cold. I thought it was a very novel name, but it never caught on like COPD. Tell us a little bit, because there are people out there who have COPD, they call it emphysema, chronic bronchitis. Tell us a little bit about what it is and anything new in treatments.
COPD is, it's categorized basically as a similar illness to asthma in that it's an obstructive pulmonary disease, chronic obstructive pulmonary disease. It's not as reversible and doesn't respond as well to medications. And it's largely related to smoking or inhalation of toxic substances. The difference is that it actually causes some structural changes within the airways, that some of the defense systems aren't functioning well, and that the structural components of what helps open up those airways actually deteriorate. So there are some different subtypes. One is emphysema, where the destruction of the lung tissue where the oxygen actually gets absorbed can be destroyed. Some people can develop what you mentioned, chronic bronchitis, where it's more like the typical smoker's cough, that they continuously cough and bring up just a lot of excess mucus on a daily basis. And those two are really the 2 main components of what we consider chronic obstructive pulmonary disease.
Any new treatments, anything different out there than over the last few years?
There are definitely new treatments. There are focus on newer medications that combine so that the synergism or the way the medications work together actually show better results than one or the other alone. There are newer modalities using bronchoscopy, which is looking into the lung with a camera. They're now doing some procedures that used to have to be done with open surgery with a bronchoscopy. So there are definitely newer methods of treatment out there.
Great, that's wonderful to hear. A couple of other quick, we'll do like little questions. Tell me about secondhand smoke. So you're not the smoker. Any thoughts about it?
And you're still at risk. I mean, patients, the individuals who have these lung diseases that you just mentioned, just from secondhand smoking, you know, the husband smoking or the wife smoking for a long time, and you don't smoke, but you do end up that way. And I think with children, as when parents smoke as well. Right?
I know that when you talk to the residents, one of the questions you actually ask patients now when they come in is, do you smoke or does someone in your household smoke? And that's become a much bigger question and bigger part of our histories.
It's definitely known that secondhand smoke can cause the same exact illnesses as firsthand smoke. There is also a dose response, so meaning the more secondhand smoke you're exposed to, the more likely you are to develop those things. And there's actually a newer term that's come about called third-hand smoking. So what that is if the particles that come off the ash or the smoke might deposit on your clothes, on the carpet, on the pet, and these particles can last a long time and actually get absorbed through the skin. They can get ingested or inhaled if they are put up into the air again, and all of those are thought to actually cause the same kind of conditions as the first and second-hand smoke.
Does marijuana cause problems in the lung, smoking marijuana?
It's known that pretty much anything that's going to be combusted, that's going to cause those kind of particles, they are going to have carcinogens, they are going to cause inflammation in the body and cause destruction and damage. So marijuana itself has not been directly linked to these diseases. It's thought that, for one, it's been hard to study, because it's been illegal in many places. The other idea is that people don't tend to smoke as much marijuana as a typical cigarette smoker. So that dose response might not actually be there. Interesting.
So it's important. I think it makes sense when you talked about smoking, tobacco, asbestos in the environment, air pollution, the idea that someone is breathing in anything that's burning with paper and chemicals is something that's, I think, not good for us. We're going to go into pneumonia a little bit. And everyone hears the word pneumonia, and it goes anywhere from a 20-year-old saying they have walking pneumonia and they're able to run the marathon with it, if they could, to an older person who many times will succumb or die from pneumonia. So Jay, tell us a little bit about pneumonia, and how does anyone know how severe it is? How do you figure it out?
There are two main groups. When the way we look at patients when they come in, you have those who come in what we call community-acquired pneumonia, and those who come in with what we call healthcare-acquired pneumonia. Community-acquired pneumonia is what you call your walking pneumonia. People come from home. They haven't been exposed to any health care facility. They haven't been in a nursing home. They haven't been in a dialysis unit. They did not just recently get out of the hospital. Those you consider community-acquired pneumonia. And it's important for us because it kind of tells you what bacteria might be involved. And then you have the healthcare-acquired, which is what you get by being exposed to the healthcare environment, being in the hospital, nursing home, or you come into the hospital for something else, and unfortunately come to the hospital for something else, and you get a pneumonia after about 48 hours in the hospital.
So the germs in the hospital are more resistant or more powerful than the germs outside?
Right. So those who have the healthcare acquired usually have resistant organisms, and they usually need antibiotics that are stronger than those that come from the community.
How do you treat pneumonia?
The main treatment is antibiotics, and the choice of antibiotics would be dependent upon what type of pneumonia you are suspecting, depending on what environment that the person may come from. But really the treatment is supportive meaning that if they sometimes are severely ill, may require extra oxygen. They oftentimes can get similar symptoms to asthma, where their airways might get inflamed and constricted and may require some medicines to help relax that. There are some people that use actually steroids, which are an anti-inflammatory, in severe pneumonia, and that's been shown to help in some studies.
So there's a lot of pneumonias. We talked about bacterial pneumonia, but just to talk, people hear on TV about Legionnaire's disease, Legionella. Tell us a little bit about it. How do you get it? And there's always that concern about people being very sick from it and hearing people have died from that.
Well, Legionella is a specific type of bacteria that can cause pneumonia. It is a bacteria that tends to colonize in certain water environments, so that if a certain facility or place has a, say, water facility that might be colonized with Legionella, that can get aerosolized into the air and it can infect many people. So that there can be outbreaks or epidemics of that particular type of pneumonia. It has a constellation of symptoms, so that typically it causes breathing difficulty, cough. It often causes confusion episodes in a lot of people. It also often causes a lot of GI symptoms, so they tend to get a lot of diarrhea, nausea, vomiting, and many times those people can be fairly sick.
So we're coming to the end, and I'll ask you about one other infectious process. When I was in medical school, people talked a lot about tuberculosis, and tuberculosis being thought of as a third world process. Are we seeing tuberculosis out on Staten Island and in the New York area, Jay?
Yeah, we do see them in the New York areas, Staten Island included. I mean, a lot of the TB that we get now, you see it in foreign-born individuals who travel into the country, and that's how we end up having so many cases. But the good thing about it is with the current screening and treatments that are given, I think we're going to have that under control.
Super. I want to say thank you to both of you. It's been really chock full of a lot of information. Pulmonary medicine is a large portion. The lungs are a big part of your body. And just really to tell everyone that if you're short of breath, coughing, wheezing, it's not normal. And please stop smoking and try to avoid any pollutants. And if you have any questions, we have wonderful pulmonologists out here. Thank you so much for being here.
Thank you for having me.
Thank you.